Hi everyone, my name is Kenzie and I am excited to provide you with an overview of my practicum project and report called Using the Health Equity and Inclusion Framework to develop a community mental health connectors training for frontline community service providers in Burnaby. Before we begin, I would like to take a moment to respectfully acknowledge that I am joining this conference today from the traditional, ancestral, and unceded territories of the Musqueam, Squamish, and Tsleil-Waututh nations. So I am fortunate to have had the opportunity to contribute to the mission and vision of the Burnaby Division of Family Practice during my practicum. As a nonprofit organization, the Burnaby Division of Family Practice connects family physicians with the community to improve local healthcare delivery and create meaningful change that benefits physicians and the community as a whole. As a brief background, my practicum project was one of the deliverables of a larger division project called Sharing Care with Community, supporting a patient-centered approach to mental health care. The Sharing Care with Community project was developed to address the poor mental health and barriers to mental health services among Burnaby community members, which were identified in the needs assessment conducted last summer. Among the key barriers identified by the community were long wait times, lack of trust in the system, high costs, and of particular importance to my practicum was the lack of community awareness of community-level mental health resources, including those that address the social determinants of mental health that are available in Burnaby. This lack of awareness of the mental health resources that exist within the community is a significant component of low mental health literacy, which creates a barrier between those who need mental health resources and their utilization of them. In turn, this hinders early intervention, which is vital for promoting positive mental health outcomes. So to ensure that community members in Burnaby ultimately benefit from the abundance of community level and non-clinical mental health resources available, as part of the Sharing Care with Community project, frontline community service staff, for example, navigators or settlement workers, are trained to be community mental health connectors. A community mental health connector, once trained, provides support to clients with poor mental health by signposting them to community level resources such as social networks or programs, and also by providing them with information on general lifestyle recommendations, self-care strategies, and goal planning. So my practicum project focused on developing the training for community mental health connectors with the aim of ensuring that frontline community service staff in Burnaby are well trained, confident, and supported in their work in promoting the positive mental health outcomes of their clients. To achieve this, an effective training development process was crucial. To this end, a learner-centered and theoretically grounded andragogical framework was employed, emphasizing health equity and inclusion, and departing from traditional teacher-centered and standard knowledge translation approaches to health education. The andragogical framework used to develop the training utilized several models and practices, but most notably was the health equity and inclusion framework that was established by the Center for Addictions and Mental Health, as shown here on the right. The health equity and inclusion framework is an evidence-based approach, which is based on the belief that effective learning requires an environment that promotes a sense of belonging, empathy, and inclusivity that allows learners to immerse themselves in the learning environment and acquire knowledge. This framework is superimposed on the ADDIE model of instructional design, which is a process recommended by the CDC and used by training developers to plan and create effective learning experiences. The ADDIE model comprises 5 phases, including the analysis, design, development, implementation, and evaluation phase, although only the first 3 phases were completed in my practicum. Additionally, the model encourages the development of learner-centered training to ensure the best methods are used with a given learner population, often based on a theoretical approach. Understanding that frontline community service staff are the training audience, predominantly representing an adult population, andragogy, an adult learning theory that is defined as the art and science of helping adults learn, was used to establish that theoretical ground. At each stage of the ADDIE model, the health equity and inclusion framework provides several considerations and examples for framework users to reference. These considerations ensure that the training responds to and respects the risks, experiences, and needs of the learners to foster inclusion, while also integrating material that highlights relevant social inequities, systems of oppression, and opportunities for health equity. Additionally, while anti-oppressive training practices are not explicitly included within the health equity and inclusion framework, they did nonetheless complement the broader andragogical framework used to develop the training. As a theory and approach, anti-oppressive training practices seek to recognize and dismantle oppressive systems such as colonialism, racism, sexism, classism in both the classroom and the training content. Shown here is an overview of the andragogical framework. Within the diagram, you can see that each phase of the ADDIE model has various tasks and activities that are required, and phase-specific health equity and inclusion considerations that are in the box below. Further, the arrows illustrate the fact that the outputs from one phase are used to begin the next. So as an example, using the outputs from the design phase, during the development phase, training material was created comprising of a facilitator's guide, PowerPoint slide deck, learning activities, and handouts. It was crucial during this phase to confirm that the developed training materials sufficiently integrated themes of diversity, inclusion, and equity, while also establishing such an environment for all learners. This meant, for example, that all of the training materials used plain and inclusive language, which avoided long sentences with multiple ideas, professional language, and language that perpetuates negative stereotypes. The utilization of the andragogical framework offered a systematic, dynamic, flexible, and theoretically grounded approach to designing tailored training for adult, non-clinical social providers. For public health educators and trainers, it is essential to adopt such a framework that prioritizes learner-centered and inclusive approaches, building trust and confidence among trainees. By doing so, public health educators can provide the best opportunities for knowledge acquisition, leading to a well-trained and self-assured workforce that is better equipped to support the communities that they serve. As I conclude my presentation, I hope to have first reminded you of the importance of a well-trained and confident social service or community workforce in achieving successful public health outcomes. This is especially important when utilizing public health approaches that involve supplanting medical professionals with community members. It is imperative that those in the public health field become familiar with the development processes necessary to accomplish this, such as those described today. My second hope is that this presentation has piqued your interest in the work being done by the division to implement a network of individuals who are passionate about supporting the community members and fostering a sense of inclusion in order to drive social action and playing an essential role in early intervention and health promotion. Thank you all for joining the session and listening to my culminating presentation. And I want to express my sincerest gratitude to my supervisors, Azra and Huey, for having me as a practicum student and providing me with their invaluable knowledge and expertise. And lastly, Dr. Jeff Masuda, Martina Nappet, and Leah Crosby for all of their support over the last 3 months.